let's go now to the real deal of systemics, and the $1 million question is about doublets or triplets. So we don't have direct comparison. We know that if we do chemotherapy, we need the ARPI, but we don't know still if we do the ARPI, we need chemotherapy. So that's the main question. So we need to take decisions in our daily routine, every patient's pros and cons. So who wants to start and how to decide about doing a doublet? So first thing, I think it's pretty much standard here that no one is using ADT alone anymore. So for the urologists that are watching us, ADT alone should not be the standard of care. So I'm not going there. So let's start with the doublets or the triplets. So when to add chemotherapy in this scenario, you do that like very common, or it's a rare situation? Well, how do you see this?
So,
go ahead.
Yes. Okay. So, in my practice, it's that higher volume, fitter, younger patient who I routinely consider for triplet therapy. We have 2 trials. Obviously, we have Piece 1. We have Arison's. Both of which demonstrate survival benefit. With in one, obviously, it's Abby Pred plus tax. The other one is going to be Dara plus tax. Both level 1 evidence supporting the use of triplet therapy in that patient population. The NCCN guidelines actually updated this year also support treatment intensification in that similar patient population with triplet therapy consideration up front, which I think is a big statement from the NCCN in that group of folks. They specifically kind of identified that subset of folks. However, with that being said, I had that conversation, but patients don't always run to chemotherapy, I have to admit, right? So it's not like I have the conversation, they automatically transition on to triplet therapy. I would say there's, anecdotally, maybe 40 or 50% of those patients fall off and go with doublets, but that's a conscious choice after a consultation with triplet.
Okay.
Yeah, it's challenging.
Can I build on that and just kind of double click into it? So did you ever view chemotherapy kind of being a gatekeeper to Pluvicto, and now with MSA4 being out, does that change how you approach that conversation?
Like if you use chemotherapy, like in the metastatic castration sensitive, and how you're going to approach the first line for castration resistant disease.
Right.
Yeah.
Once they progress, it's really hard to get chemo because they usually stick with that.
Yeah, it's hard.
I think it's a great question, and to me, historically, no, I haven't. But I viewed it basically as my one best shot on goal for a sick young patient. And assuming they're on board with that, we had the level 1 data to support that. But they get bad neuropathies. They get side effects associated with this. They get bone marrow suppression. They get GI side effects. So it's not something that is without its potential risk. And those neuropathies can be profound and persistent, right, for the rest of their lives. So I think it's something that they need a good conversation up front, and they need to have a kind of informed decision around what the risk and benefit is, because we don't have head-to-head data, as you alluded to.
Exactly. We don't have that.
Yeah, it's very tough on the patient. It's like you're throwing all this stuff at them right away. They just learned.
So
most of these patients are de novo, right? So you're throwing everything up there right at front. And so you have to kind of stratify if that patient's going to be comfortable with doing this, The other thing I'd love to see is a true trial that looks at doublet therapy followed by taxanes later on down the road versus triplet up front. Because the studies you discussed don't quite look at that in a true stepwise fashion, right? And so does it make a difference if you give the taxanes up front, or can you hold on to it in your back pocket for down the road?
I was about to ask the question because in real life, I always think that maybe patients that you are starting with the doublet, but you're not seeing, as Gregory mentioned before, the nice PSA response in the first few months, because we're expecting with most of the drugs, something around 3 to 4 months, you should see some PSA response. Maybe 6 months, that's it. I mean, you should see a very nice PSA response. Let's say you're not seeing a very nice PSA response with a doublet. However, this patient is in response. I mean, this is not castration-resistant disease. Mm-hmm. Would you think about adding chemotherapy in that scenario? And we do have actually a trial, which is the triple switch trial. It's a Canadian trial that is, I think, is already recruiting, and they're actually asking exactly that question. So the question is, you do ADT doublet, ADT ARPI, very nice PSA response and detectable, you keep it. Patients are not doing that well. The PSA response is not below, I think the threshold is 0.2.
Yeah.
If it's not 0.2, they randomize this group to keep the ADT,
Mm-hmm.
doublet, and ARPI, or then get chemotherapy. So, and I think it's very nice and exactly what is your question.
Yeah.
I have the feeling that those patients need chemotherapy, but not sure if you.
I'd be
agree.
interested to know their germline mutation status too, like any HHR mutation.
Maybe this group that did not respond has higher chance of being in a specific mutation, because now we know like those, like the triple negative for prostate cancer, like PTEN loss, RB1 loss, or the SPOP mutation that actually most likely will respond much better with hormone therapy. I think that they're going to be most likely they will be doing something with this trial. I think that's going to answer that question.